I'm Dr. Robert Hastings, an emergency medicine physician at St. Augustine Medical Center in Springfield, Massachusetts. Or rather, I was until I handed in my notice last month and walked away from everything I'd built over 14 years of practice. I earned my medical degree from Boston University School of Medicine in 2009, finished my residency at Yale New Haven Hospital, and spent more than a decade working in one of the busiest emergency departments in New England. My credentials included board certifications in both emergency medicine and critical care. During my time in the ER, I treated somewhere north of 40,000 patients. Everything from minor lacerations to multi-vehicle pileups, from routine chest pain to trauma codes that required cracking a patient's chest open right there in the bay. I thought I'd seen it all in emergency medicine. I once treated a construction worker who walked into our department with a piece of rebar penetrating his skull from temple to temple, and he was asking me about parking validation. I witnessed a drowning victim who'd been underwater for nearly an hour come back with 0 neurological deficits. I've managed bizarre drug reactions, diagnosed rare diseases that most doctors only read about in textbooks, and documented medical oddities that ended up in peer-reviewed journals. My understanding of human physiology felt unshakable. I knew the boundaries of what was possible, what the human body could survive, and what fell within the realm of medical explanation. What I'm about to share destroyed that confidence completely. This case made me question the fundamental principles I'd relied on throughout my entire career, and eventually drove me to leave medicine altogether. It started as a seemingly routine trauma call on a quiet October night, the kind of shift I'd worked countless times before. The patient who came through our doors that evening did things that were medically impossible, not in the rare but documented sense, but in a way that violated the basic laws of human biology. St. Augustine Medical is a Level 2 trauma center, a sprawling complex of gray concrete and glass that serves the greater Springfield metropolitan area. The emergency department where I worked occupies the entire ground floor of the East Wing, 42 beds divided into color-coded zones, state-of-the-art imaging equipment, and a dedicated trauma suite that could handle anything short of a declared mass casualty event. I knew every corner of that department, every quirk of the equipment, every shortcut through the supply rooms. It was my domain, and I was confident in it. The night of October 14th, 2024, began unremarkably. I clocked in at 18:47 for the night shift, received handoff from Dr. Dorothy Mitchell, and settled into what looked like a manageable evening. The board showed the usual mix: chest pain in Bay 3, abdominal pain in 7, a possible fracture in 12, and several minor complaints in the fast-track area. The attending physician coverage was solid, nursing staff fully deployed, and our trauma surgeon, Dr. Harold Pemberton, was in-house for backup. Everything was exactly as it should be. At 21:33, the radio crackled with an incoming ambulance notification. Dispatch reported a 28-year-old male found unresponsive in Forest Park, Glasgow coma scale of 3 at the scene, the lowest possible score, indicating complete unresponsiveness. The paramedics reported agonal breathing, fixed and dilated pupils, and a core temperature of 89.2 degrees Fahrenheit. Estimated time of arrival, 6 minutes. I grabbed charge nurse Barbara Thornton and headed to Trauma Bay 1, calling out orders as we walked. Respiratory therapy was already positioning the ventilator. The trauma team assembled with practiced efficiency. 2 additional nurses, a pharmacist, a radiology tech standing by with the portable X-ray machine, and a lab technician ready to run stat blood work. We'd done this dance 1,000 times. The ambulance bay doors burst open at 21:39. The paramedics wheeled in a young man strapped to a backboard, his clothes soaked through with what appeared to be muddy water. Lead paramedic George Anderson gave report while they transferred him to our gurney. "This is Thomas Whitfield, 28 years old, found face down in a creek bed by hikers approximately 45 minutes ago. No pulse on scene, started CPR immediately, got return of spontaneous circulation after 3 rounds of epinephrine. GCS remains 3, pupils fixed at 8 millimeters bilaterally, no gag reflex, temperature 89.2 rectally. We've got him on 15 liters non-rebreather. maintaining oxygen saturation at 87%. No medical history available. No identification except a gym membership card in his wallet. I moved to the head of the bed, assessing quickly. Thomas Whitfield looked like any other drowning victim I'd treated. Pale, cold, unresponsive. His chest rose and fell with irregular, gasping breaths. I checked his pupils with my penlight. Fixed and dilated, unresponsive to light. Classic sign of severe anoxic brain injury. "Let's intubate," I said. "Barbara, get me an 8.0 ET tube, video laryngoscope. Start active warming protocols, bear hugger, warm IV fluids, heated humidified oxygen once we've got the airway. I want a full trauma panel, tox screen, CBC, CMP, coags, blood gas, lactate level. Get CT scheduling on the line for a pan scan as soon as he's stable enough to travel." The intubation went smoothly. I visualized his vocal cords on the video screen, passed the endotracheal tube, confirmed placement with capnography showing a good waveform, and end tidal CO2 of 52. We secured the tube, connected him to the ventilator, and I auscultated his lungs. Clear bilaterally, equal breath sounds. His oxygen saturation climbed to 94%. But something felt wrong. I couldn't articulate it yet. Just a nagging sensation at the base of my skull that something about this patient didn't fit the pattern. His initial vitals came back. Heart rate 118, blood pressure 94/62, respiratory rate controlled at 16 by the ventilator, temperature still 89.8 degrees despite the warming blanket. The cardiac monitor showed normal sinus tachycardia, fast but regular. No arrhythmias. "Get me an ultrasound," I said. "I want to see his heart." I placed the probe on his chest and stared at the screen. His heart was contracting normally, all 4 chambers squeezing in coordinated rhythm, valves opening and closing properly, no obvious structural abnormalities. For a drowning victim who'd been in cardiac arrest, his heart function looked remarkably preserved. The lab results started populating on the computer screen. I scrolled through them, frowning. His complete blood count was normal. Electrolytes normal. Liver function normal. Kidney function normal. The toxicology screen was negative for everything. No alcohol, no drugs, no carbon monoxide. His arterial blood gas showed mild metabolic acidosis, expected after cardiac arrest, but nothing catastrophic. His lactate was elevated at 6.2, high but not incompatible with recovery. Everything looked too good. That was the problem. A drowning victim who'd been without a pulse for an unknown duration should have shown more damage. His organs should have been failing. His blood chemistry should have been deranged. Instead, aside from the hypothermia and the coma, he looked like someone who'd just run a marathon, stressed but not dying. "Temperature check," I called out. 91.3, Barbara replied, coming up slowly. At 22:15, 43 minutes after arrival, Thomas Whitfield's core temperature reached 93.1 degrees. His blood pressure had stabilized at 108/68, heart rate down to 94. The warming blanket hummed quietly, and heated up V fluids dripped steadily into his veins. He remained deeply comatose, completely unresponsive to painful stimuli. His pupils were still fixed and dilated. I was documenting my findings when Barbara called out sharply, "Dr. Hastings, his eyes are open." I spun around. Thomas Whitfield's eyes were indeed open, staring straight up at the ceiling with those massive, unresponsive pupils. It wasn't unusual for comatose patients to have their eyes open. Reflexive eye opening could occur even in deep coma states. But something about his gaze made my stomach tighten. "Pupils still fixed?" I asked, moving to his bedside. Barbara checked with her penlight. No response. Still 8 millimeters bilaterally. I performed a full neurological exam. No response to verbal commands. No response to painful stimuli. I pressed hard on his nail beds, rubbed his sternum, applied pressure to his supraorbital ridge. Nothing. No grimacing, no withdrawal, no posturing. His limbs were completely flaccid. Glasgow Coma Scale still 3. By every objective measure, he was in a deep coma, with signs of severe brain damage. But his eyes tracked me as I moved around the bed. I stopped mid-step, watching. His head didn't move. It remained centered on the pillow, locked in place by the cervical collar. But his eyes followed me, smooth and coordinated, as I walked from his right side to his left. "Barbara, are you seeing this?" She nodded slowly, her face pale. "That's not possible. His GCS is 3. "I know." Coordinated eye tracking required intact brainstem function, cortical processing, and voluntary motor control. A patient in a deep coma with fixed, dilated pupils couldn't track visual stimuli. It was neurologically impossible. I held up my hand and moved it side to side. His eyes followed. I moved my hand up. His eyes tracked upward. Down. His eyes followed down. "Get Dr. Pemberton down here," I said quietly, "and call neurology. Tell them we need an urgent consult." I performed another painful stimulus test, digging my knuckles hard into his sternum. No reaction, no increase in heart rate, no muscle tension, no withdrawal, no change in his expressionless face, but his eyes remained locked on mine, following every movement with perfect precision. Dr. Pemberton arrived at 22:31, took one look at the patient, and performed his own neurological assessment. He got the same results I had: complete unresponsiveness to everything except visual tracking. "This doesn't make sense," he muttered. "Fixed pupils don't track. That's basic neurology." "I know." "Have you checked the pupils again? Maybe they're not actually fixed?" I checked again, shining my brightest pen light directly into each eye. The pupils remained dilated at 8 millimeters, not even a flicker of constriction. But those eyes continued to track us, both of us now, swiveling back and forth as we moved around the bed. The neurology resident, Dr. Ellen Kowalski, arrived at 22:47. She was young, maybe 2 years out of medical school, but sharp. I gave her the rundown while she examined Thomas Whitfield herself. She stood back, looking disturbed. "I want to try something," she said. She pulled out her phone and opened a video. Some kind of moving pattern, swirling colors. She held it up in front of his face. His eyes tracked the patterns, following the swirls and movements with perfect precision. "Cortical blindness doesn't track," she said softly. "Brainstem damage doesn't track. Severe anoxic injury doesn't track. He shouldn't be able to do this." "But he is," I said. "We need an MRI," she said. "I need to see his brain." We arranged for an emergency MRI at 23:15. It took 4 of us to transport him safely. He was still intubated, still on the ventilator, still requiring continuous monitoring. The radiology tech, a veteran named Walter Green, helped us position Thomas in the scanner. I stayed in the control room, watching through the window as the massive machine hummed and clicked, generating slice after slice of detailed brain images. The pictures appeared on the screens in front of me, and I felt my mouth go dry. His brain was structurally perfect. No edema, no bleeding, no signs of ischemic damage, no areas of abnormal signal that would indicate stroke or anoxic injury. The gray matter and white matter showed normal differentiation. The ventricles were normal size. Every structure, cerebral cortex, basal ganglia, thalamus, brainstem, cerebellum, looked exactly as it should. "That's impossible," Dr. Kowalski whispered beside me. "He was in cardiac arrest. He had no pulse. His brain should show damage." "Pull up the diffusion-weighted images," I said. She clicked through the sequences. The DWI images, which would show acute ischemic changes within minutes of injury, were completely normal. No bright spots indicating cytotoxic edema. No areas of restricted diffusion. Nothing. "His brain is normal," she said. "Completely, entirely normal, but he's in a coma with fixed, dilated pupils." We returned Thomas to Trauma Bay 1 at 0023. His temperature had reached 96.8 degrees. His vital signs remained stable, and his eyes continued to track every person who entered his field of vision, despite his complete lack of response to any other stimulus. I sat down at the computer and began documenting this impossible case: a patient in deep coma who could track visual stimuli, a drowning victim with cardiac arrest who showed no brain damage, fixed dilated pupils that somehow still transmitted visual information to a brain that processed and responded to it. At 1:15, I noticed something else. The ventilator display showed him triggering breaths above the set rate. The machine was set to deliver 16 breaths per minute, but he was initiating 22. That meant his brainstem respiratory centers were functioning, sending signals to breathe. Normal for a patient recovering from sedation or improving from coma. But Thomas Whitfield wasn't improving. His Glasgow coma scale remained 3, his pupils remained fixed, and he remained completely unresponsive to everything except visual tracking. "Barbara, what's his minute ventilation?" She checked the ventilator screen. 8.2 liters per minute. That's high for his size. It was high. He was breathing more than he needed to, over-breathing the ventilator. His arterial blood gas from an hour ago had shown mild acidosis, which should make someone breathe more, but not like this. And patients in deep coma didn't typically have coordinated, strong respiratory drive. I adjusted the ventilator settings to let him breathe more on his own, watching the waveforms carefully. His respiratory pattern was regular, coordinated, strong. The waveforms looked like someone who was awake and breathing normally, not someone in a coma. At 2:17, the night nursing supervisor, Gladys Freeman, came by to check on the unusual case she'd heard about. She stood at the foot of the bed, and Thomas Whitfield's eyes immediately locked onto her. She moved to the left. His eyes followed. She raised her hand. His eyes tracked upward. "Lord have mercy," she whispered. "I've been doing this for 38 years, and I've never seen anything like that." "Neither have I admitted. At 3:30, I made the decision to try an EEG, an electroencephalogram to measure brainwave activity. Maybe the electrical activity in his brain would explain what his anatomy and physiology couldn't." The EEG technician, a tired-looking man named Raymond Potter, arrived at 4:05 and spent 20 minutes placing electrodes all over Thomas Whitfield's scalp. The EEG started recording at 4:31. I stood next to Raymond, watching the lines trace across the screen. EEGs in comatose patients typically show very slow waves, suppressed activity, or in severe cases, nearly flat lines with minimal activity. Thomas Whitfield's EEG showed normal waking alpha rhythms. "That's not right," Raymond said, adjusting the settings. "Let me check the electrode placement." He verified every electrode. All properly placed, all making good contact. The EEG continued showing normal waking brain activity, the kind of patterns you'd see in someone sitting quietly with their eyes open, alert and conscious. "His brain is awake," Raymond said quietly, "but he's in a coma." "How is his brain awake?" I had no answer. Dr. Kowalski returned at 6:15 for another assessment. Thomas Whitfield's neurological exam remained unchanged. GCS of 3, no response to pain, no response to commands, completely flaccid limbs. But his eyes tracked her every movement, and his EEG showed a fully conscious brain. "I need to present this to the attending neurologist," she said. "Dr. Zimmerman needs to see this personally." Dr. Lawrence Zimmerman arrived at 7:42, a gray-haired man with 40 years of neurology experience. I walked him through everything: the drowning, the cardiac arrest, the normal labs, the perfect MRI, the tracking eyes, the waking EEG, all of it. He listened without interrupting, his expression growing more troubled with each detail. He examined Thomas Whitfield himself, spending 30 minutes performing the most thorough neurological assessment I'd ever witnessed. When he finished, he stood silent for a long moment. "I cannot explain this patient," he finally said. "Everything we're observing is medically contradictory. He has signs of the deepest possible coma alongside signs of full consciousness. His brain shows no damage but isn't functioning normally. He's responsive and unresponsive simultaneously. This patient shouldn't exist." "So what do we do?" I asked. "We continue supportive care and monitor him closely. Maybe as his body temperature fully normalizes, things will become clearer. Maybe there's some toxin we haven't identified yet. Maybe this is some syndrome I've never encountered. But right now I have no explanation." Thomas Whitfield remained in our ICU for the next 3 days. His temperature normalized. His cardiac function remained strong. His lab values stayed perfect. His MRI, repeated on day 2, remained completely normal. His EEG continued showing waking brain patterns. His eyes continued tracking anyone who moved within his field of vision, and he remained in a coma, GCS of 3. completely unresponsive to everything except visual stimuli, unable to breathe on his own when we attempted to wean the ventilator. On the fourth day, his heart stopped at 14:22. We initiated CPR, pushed medications, shocked him twice. Nothing worked. He was pronounced dead at 14:51. The autopsy, performed by the medical examiner, Dr. Virginia Walsh, found nothing. No signs of drowning in his lungs, no brain damage, no evidence of trauma or disease. His organs were all normal. Toxicology was negative for everything tested. The official cause of death was listed as cardiac arrest of unknown etiology. The initial incident that brought him to us was listed as near drowning with anoxic brain injury. But Dr. Walsh noted in her report that no evidence of anoxic injury was found on autopsy. That case stayed with me. It haunted me. I found myself questioning every comatose patient I treated afterward, wondering if their brains were awake inside unresponsive bodies, if they were seeing us and tracking us while appearing completely unconscious. Then it happened again. 6 weeks later, on November 28th, we received a 53-year-old woman named Linda Cartwright, found unresponsive in her home after a suspected overdose. GCS of 3, fixed and dilated pupils, hypothermic. We stabilized her, intubated her, and started warming her. Her labs were perfect. Her brain imaging was normal. And 2 hours after arrival, her eyes opened and began tracking us around the room while she remained deeply comatose. Her EEG showed normal waking patterns. She died 4 days later of cardiac arrest. Autopsy found nothing. The third case arrived on January 9, 2025. 19-year-old male, Jacob Morris, pulled from a frozen pond. Same presentation, same impossible findings, same outcome. After Jacob Morris died, I went home and wrote my resignation letter. I couldn't keep practicing medicine when I no longer understood what I was treating. Were these people conscious, trapped inside paralyzed bodies, watching us with those tracking eyes while we discussed their prognosis and considered withdrawing care? Or was this some bizarre physiological phenomenon that mimicked consciousness without actual awareness? I couldn't answer those questions, and I couldn't keep working in that uncertainty. I submitted my resignation on January 24th, 2025. My last shift was February 14th. I walked out of St. Augustine Medical Center after 14 years, and I haven't been back. I still think about Thomas Whitfield, about his eyes following me around that trauma bay, watching me with perfect precision while every test said he was deeply brain damaged, about his normal brain that showed waking patterns while his body lay unresponsive, about how he existed in two contradictory states simultaneously, both conscious and comatose, both brain damaged and neurologically intact. The medical literature has no explanation for what I witnessed. I've searched. I've read everything I could find about coma, consciousness, anoxic brain injury, and disorders of awareness. Nothing matches what I saw. Some of my former colleagues think it was some bizarre syndrome we don't understand yet. Others think it was a series of unusual but explainable cases that I'm misinterpreting. Dr. Zimmerman, before he retired last month, told me he'd never seen anything like it in his entire career and couldn't offer any rational explanation. I wonder how many other emergency physicians have seen patients like Thomas Whitfield and dismissed the tracking eyes as random movement or reflexive behavior. How many comatose patients with fixed dilated pupils have been lying in ICUs with fully conscious brains, watching and aware, but unable to respond? How many times have we stood at bedsides discussing withdrawal of care while the patient watched us and understood every word? I don't know the answers. I don't know what Thomas Whitfield was or what happened to him in that creek bed in Forest Park. I don't know if he was conscious or if his body was just doing something that looked like consciousness without actual awareness behind it. I don't know if those tracking eyes meant someone was home, trapped and terrified, or if they were just meaningless movements produced by a dying brain. What I do know is that I can't be an emergency physician anymore. Not when I've seen impossible patients who exist in contradictory states. Not when I've watched people die who were simultaneously brain dead and neurologically intact. Not when every comatose patient makes me wonder if they're watching me from behind those supposedly unresponsive eyes. Medicine is supposed to make sense. The human body follows rules, operates according to principles we can understand and predict. But Thomas Whitfield broke those rules, and I watched him do it. And once you've seen something that shouldn't be possible, you can't unsee it. You can't go back to that comfortable certainty that you understand how the world works. So I'm done. I'm not a doctor anymore. And sometimes late at night, I still see those eyes tracking me across the trauma bay. Watching, following, seeing everything while the medical monitors said nobody was home. I'll never know if Thomas Whitfield was conscious in there, aware and trapped. But I can't stop wondering. And I can't stop asking myself the question that ultimately drove me from medicine. What else have I misunderstood?